So thanks so much for having me come out here. I do want to thank my aunt and uncle for coming, getting their CME credits. Yeah, it's been a busy 2 weeks at Northwestern, I'll just say that. But I did bring the Chicago weather with me. But I spent the last few years as Associate Chief Medical Officer at the hospital, and so I think what I'm going to really do is take an educator's view and go from the classroom to the bedside, maybe back to the classroom, back to the bedside, and try to think a little bit about quality improvement and things I've been working on in the hospital in the past few years from an educator's point of view. Okay, I do want to mention that we have a potential conflict of interest with some of the simulator companies. Simulab and Northwestern have joined together to use our central line curriculum. It's actually going out to about 60 different VAs. So Northwestern University will get some royalties from this. I haven't received anything personally, although, you know, be happy to talk to them. But I just wanted to make sure I mention that. So when you see this, this is some residents practicing in the sim lab doing advanced cardiac life support. And if I asked people to go around, I won't call on anyone, but if I asked people and said, what do these residents need to know in order to provide advanced cardiac life support care on a real patient that is AHA compatible and is high quality care? And I think that I would get answers like this. They need, you know, get the oxygen and the monitor on the patient. They need to get the AED out and make sure they know how to use it. And they obviously need to know the ACLS algorithms. These answers are all right, and obviously these residents need to know that. But I'm going to ask you this question again at the end of the talk and see if we can add anything to the list based on what we talk about. Okay, so objectives that I'd like to go over in the next 45 minutes or so is to review how medical education rates as a quality improvement tool. So I'm a medical educator at heart. How well are we thought of as in the quality improvement world? To mention what Rena talked about a little bit, to talk a little bit about what I call education best practices of deliberate practice and mastery learning and how I think those are superior to traditional learning strategies in a variety of different competencies. And then to get you thinking about some translational science studies that use education to improve patient care. Okay, so how does medical education rate as a quality improvement tool? Well, you can see that, I'm not sure how far I can walk, but you can see it rates pretty low. So this is the Joint Commission rating of quality improvement tools. And you know, things that people talk about a lot are not letting people do something, automation, checklists. Education is rated at the bottom next to the mom saying, you know, just be careful. The VA agrees. Education is also listed at the very bottom here. Right above, let's just talk about it some more. So education is not really thought to be a powerful quality improvement tool. So I'm going to argue that maybe all education isn't the same, and that what people are thinking about of education is traditional lecture-based format. So I hope that you'll think this is a good lecture, but no, a lecture does not change anyone's life. A lecture is a passive experience, as opposed to some of the more active education strategies that I'm sure you're engaging in with your students and residents here at Sinai. And this is an example from Science. It was published a few years ago. If you're a Nobel laureate, you can get your med ed paper published in Science. Otherwise, you have to settle for other journals like me. But what they did was they took a large-scale physics class and they divided it into two groups, and they had ostensibly the Nobel laureate teach one side of the class, and then they had a TA teach the other side of the class using sort of the flipped classroom idea where the students would read in advance and then come to class and do problem-based learning in the classroom. And so they compared the outcomes of student engagement and how they did on the test compared to the Nobel laureate versus the TA, and guess what? They found that the students assigned to the TA had double the learning outcomes when they used the deliberate practice approach. So maybe all education isn't the same, and that people are thinking about education based on the old way of just lecture-based format. Maybe we can add to the discussion as educators about the power of education if we do it right. So what are those best practices I talked about? I want to highlight 2, and there certainly are more, but the ones that I've used and operationalized the most are deliberate practice and mastery learning. So Anders Ericsson is the world's expert in deliberate practice. I just saw him last week. He gave a talk at Madison. I highly recommend reading his article in Academic Medicine from 2004. He makes you think about things a different way with his background in psychology. And deliberate practice is this series of steps. And I put some words in red because I think they're important. I think the motivation of the learners is really key. So in all the things I go through that I'll give you specific examples, we pick things which the learners are engaged. So we pick things that they need to know in real life, maybe they're a little afraid of, and that they really want to learn. If you pick things that the students or residents don't feel is relevant to their job, I'm not sure they're going to be as motivated to participate. Your learning outcomes may not be as robust. There's well-defined learning objectives with appropriate difficulty. This idea of focused, repetitive practice. So if anyone took piano lessons as a kid, my mom used to say, go practice the piano, and you know what happens after that. But when the teacher is there and says, play the scales, play the scales, play the scales, it's a different situation, right? You're being observed, you're being monitored. It's very set, right? You do this scale, then you do this, then you do that. That's deliberate practice. So the engagement of the instructor and how tiring it is for the learner. So sending surgery residents to the sim lab and say, go play with the equipment, that's not deliberate practice because there's no focused objectives. There's no precise measurements, and there's no informative feedback unless you have a haptic simulator that can give feedback. There's a mastery standard, and then when you reach that mastery standard, you move on to the next unit. So this is a figure from Dr. Ericsson, and when you think about it, I used to be a residency director, and I would think about each of these areas as different competencies. The key of this slide is that performance directly relates to deliberate practice, whether it's in musicians, chess players, doesn't matter. So I used to think about this as advanced cardiac life support. This is breaking bad news to patients. This as doing handoffs. And this is, admitting a patient with chest pain from the emergency room, however you think about it. And when you add up those different skills and they master each level and move on to the next one, then I said, okay, you're ready to graduate and be unsupervised in internal medicine. So that's how I think about the idea of deliberate practice within a GME program. So mastery learning is what I use with deliberate practice. This is not a new idea. It came from elementary school education. Block wrote about this in the 70s. The idea that, kindergarten doesn't end in June. Kindergarten ends when the kindergartners have mastered the curriculum. And so instead of having different people at different levels all going to first grade, you would think about it as when you got these competencies, you go to first grade. And think about everything we do in medical education is really time-based because you do 12 weeks of junior medicine, soon to be 8 weeks of junior medicine, but that's another story. And at the end of junior medicine, everyone is different, right? All Northwestern students are awesome, but some get an honors in junior medicine and really grasp the material and are ready to admit patients by themselves. Some students get a pass. They're pretty good and they could see a patient and make an initial management plan, but maybe they need a little help discussing whether this was really pneumonia or PE, a little finesse. And then maybe there's a marginal pass who barely got it but, didn't fail. So what if junior medicine was instead time-based? What if junior medicine lasted until you achieved these 6 areas? So let's say you admit a patient, 6 different patients from the emergency room, you do a history and physical, you make an assessment plan, you order laboratory and diagnostic tests, you can explain your rationale to the attending and present the patient coherently, call a consult to explain the case and maybe explain what's going on to the patient and family. And there are 6 of those, and you write them up and you see them, and you also take a written test, and when you achieve the minimum on that, that's when junior medicine ends. Maybe some people need 6 weeks, and maybe some need 14. But the idea in mastery learning is what is in the bottom of the slide is that outcomes are uniform. So at the end of a mastery learning program, there is no variance. There's none of this. Everybody is here because the uniform outcomes are very similar and strict. And people think about mastery learning as you have to do well on the test. You know, you have to pass the test and then you move on, which is really a simplification of the idea of mastery learning. Mastery learning starts with a baseline test. And the idea with the baseline test is that you have to know what the learner doesn't know, so you can focus on the education program. So in ACLS, for example, we have a lot of residents who know how to use the defibrillator in the AED but don't know how to do the transcutaneous pacemaker. So you find out on the pre-test what everybody doesn't know. So there's a lot of steps to mastery learning, and it is important that you achieve the minimum standard and then you can move on, but there's a lot more to it than that. So I want to go through a couple of examples. I've spent a lot of time, as Rena said, working with simulation, doing simulation-based mastery learning, but it's not all high fidelity, expensive simulators. We do very little, actually none, except for ACLS training in the simulator center that I now manage. We actually have a classroom built out of 2 empty offices in hospital medicine, and we have a camera kind of hung from a hook in the ceiling, and we do all our training there because, you know, you don't need, honestly, a very fancy setup to do a lot of this training. Some of it can be done in a classroom. So examples of things we use, simulation-based mastery learning, you know, can this work in real life? Everyone's busy, and, you know, can you operationalize these type of curricula? So I think the answer is yes. We do it with the students with cardiac auscultation and Harvey. I bet you have a Harvey, right? Yeah. We do task trainer type things like lumbar puncture. We do it to mastery. And then we do communication skills. So that's code status discussion, where the simulator is the standardized patient. So this is actually an actor who has been trained to be a terminally ill cancer patient. And this is the teaching session. So you can see there's kind of a high faculty, these are faculty and these are residents, faculty to resident ratio. And we go over it again and again, how it's done, they each practice. And at the end, there's an individual assessment with the standardized patients. And it's so realistic and difficult for this actor that he can only do about, you know, 5 in a day because it becomes overwhelming. So it's pretty realistic and actually not very expensive to do these kind of things. This is our intern boot camp. So we now had 81 interns this year. Internal medicine, neurology, emergency medicine, anesthesiology, and general surgery. So yes, you can get along with internal medicine and general surgery at all. And so this is what we do with mastery learning, is that we test the incoming interns in the light. We pre-test and post-test, and then here's the minimum standard. So before you're allowed to graduate from boot camp and do this on a real patient, you must meet the minimum standard. So we do some remediation as necessary. A couple of interesting things to point out is you can see the wide sort of variation in skills at the pre-test, the huge jump after training, the smaller variation skills at post-test. This is the one that took the most time to remediate, code status discussions. Very hard to teach residents, probably needs to start earlier in the UME curriculum. Since writing this paper, we've added EKG interpretation, chest x-ray and abdominal film interpretation focused on tubes and lines and things you need to know, and handoffs. So again, as part of orientation, all the interns do this. So it is kind of possible. Can you operationalize mastery learning into UME and GME? I think the answer is yes. Okay, so why should we bother? It's a lot of work. You've got to set up a curriculum. You've got to have a pre-test and a post-test. It takes faculty time. You've got to get the standardized patient trained. Is it worth it? I think that's a fair question. So what are the advantages of this approach of mastery learning over traditional education strategies? So I think we just have to accept the fact that our traditional education has some limits. I don't think it matters what medical school you're at, what GME center you're at. Monica Lipson has published this at Michigan. I think everyone respects University of Michigan as a real outstanding center of GME. But when they take their interns through these basic skills stations, they find a huge variation in what the interns can do. And some of the tasks are, obtain informed consent, do a suture, and maintain sterile technique. I mean, these are pretty basic incoming intern skills, and not everybody can do them. So I think we just have to accept that we do a really, really good job, but there are gaps. There was a recent article in, I think, the Annals about practicing internists and their lack of knowledge of treating childhood cancer survivors. So it doesn't really matter if you get at this from practical skills or medical knowledge. There are definitely gaps in the traditional way that we educate people. So I think we just have to accept that traditional training does not equal competence. So my uncle already knows this because he's a neurologist, but we went around to 3 neurology programs in Chicago with a LP simulator and a clinical scenario, and we had the neurology residents, PGYs 2, 3, and 4, do a simulated lumbar puncture. Some had done up to 50 in actual clinical practice. And we said, okay, we have a patient who has acute headache, you've decided to do a lumbar puncture, here's your kit, go. And this is how the residents did. So despite a minimum standard not at 100%, only 2 of these very accomplished residents were able to do the procedure above our minimum standard. And one of the instructors of the residents, the program director, asked to do it also and inserted the spinal needle upside down. So this person had been teaching the residents how to do it and was also not competent in their technique. So when you insert the needle upside down, it increases the risk of spinal headache. It's just not supposed to be done that way. Anyway, so there were some gaps. We asked the residents at the end of doing this you have the fluid, what should you do with it? And the correct answer was cell count, protein glucose, gram stain. 50% got it right. Could name all 3 of those. So, as a patient, if someone's gotten spinal fluid from you, you want to be confident that people know what to do with it. So training does not necessarily equal competence. Now we can put people in the sim lab, and we can give them a 2-hour training session in the sim lab and say, okay, we've trained them, and now look how much better they do. I feel really good. Because now here are the residents. They've all had a course. Their mean is 93. The standard deviation has shrunk almost in half. I feel great. Very significant. I'm going to write a paper. This is a good day. So what is the problem with this?
How long does it last?
Well, that's a good question, and we could talk about that later. The immediate problem to me is the 6 here below the line. So the 6 students or residents have taken the course, but they're still below the line. They didn't pass. That's a problem with using the mean as opposed to the individual approach. So all of the medical students had a much higher post-test score in internal medicine than they did before they took the rotation. But what about the people who didn't get it? I mean, that's why the mean is so deceptive. So this, to me, is the limits of traditional educational outcomes. We do an intervention, everyone gets better, we feel good. But as a patient or a patient's family member, I'm not sure you want one of these people doing your LP. So this is mastery learning. We take it a step further. Here we show the 6 is the pretest, the 6, this is better, this is good. We shouldn't feel bad as medical educators. I mean, we've done a lot of good work here, but I think this is better, and this is what we should be shooting for. That's why I call it a best practice. So those 6 residents go back to the sim lab, they have additional deliberate practice, and then they pass the test, then they move on. So no one does the LP on a patient unless they can demonstrate in the sim lab that they've done it. Now remember, we also do this for handoffs, for EKG reading, for difficult conversations. There's a lot of literature coming out now about the trauma that ICU patients and their families suffer when patients spend a long time in the ICU. And our handling of some of these conversations may be affecting that. So there's a lot of work still to be done in areas like communication skills, if that resonates with anybody. This was a review of the literature that we did a few years ago in academic medicine to look at this, to say, let's compare head-to-head traditional medical education and simulation-based education with deliberate practice. And so our conclusion after doing this meta-analysis is that it's not even really close. It's that no study favored traditional education, and that rigorous education with those best practices I talked about, deliberate practice and mastery learning, yields superior education outcomes. So all education is not the same. If you have ambitious goals for your students, for your residents, for patients, we have to think about using education best practices. Okay, so now I want to give you some concrete examples. We've already, I hope I've convinced you that spending the extra time doing deliberate practice and mastery learning will lead to superior classroom outcomes. But now I want to go outside the classroom and think about the bedside. And does medical education research qualify as translational science? Do the quality improvement teams at your hospital, my hospital, need to think about education more? Are we missing an opportunity to contribute to the quality improvement literature, to the quality improvement practices at our hospitals and institutions, to the discussion nationwide about how to improve our patients' health care? So first, I just want to think about some definitions, extending the endpoint. So looking at this through the translational science levels, T1, T2, T3. So medical education interventions can be at any of these levels. So T1 outcomes are classroom outcomes. They are improved knowledge, skills, attitudes, and professionalism. They occur in the sim lab or classroom. Obviously a key component of a UME or GME program to show that your students and residents have acquired knowledge. T2, it shows increased patient care practices. So things that you've taught them transfer to the bedside and are performed in actual clinical care. Translational science 2. Translational science 3 outcomes, which I'm going to show you, benefit patients, outcomes, public health outcomes, communities, cost savings. T4 is something we've been talking about since this paper was published, that we think are skill retention, which someone asked about, and impacts on other groups of people who are not the initial target of the intervention. So if you do a rigorous education intervention for this group of people, do you have impacts downstream on other people who did not receive the education? I think the answer to that is yes. That is a really cool area of research that I think we're just getting interested in. And this layers on the Kirkpatrick levels just fine. I know we spent a lot of time thinking about Kirkpatrick levels. So T1 outcomes are reaction and learning. They liked it, they learned something. T2 is their behavior changed, and T4, level 4, what are the results? That kind of is, to me, is T3. All right, so I'm going to take you through a series of studies I've participated in and some other examples and show you how I think education practices improve patient care and what we as medical educators can contribute to quality improvement, the missing link. I thought that was a good title. All right, here's central venous catheter insertion in our ICU. We did a 4-hour curriculum for emergency medicine, internal medicine residents. Who puts in your central lines here, Rena? Do residents do it? Yeah, okay. So same as us. So here is a resident practicing in the, this is that old converted office I told you about. Here's a table. We bought the ultrasound. We use expired hospital kits. You can actually reuse a lot of those kits. You can get, the thing that happens with the central line kits is the wires bend after a while. And we can get 100 wires for $15. So we run this actually extremely cheaply. We get 1 gown per person. Sometimes they get kind of sweaty because it's hard work. So, we tell them, watch out. Okay, so here's just to show you what's going on. This is an assessment. So the resident is doing the central line insertion here, and then we have the faculty member grading on a checklist. We use checklists because they work. It's easy to calibrate between observers. We use checklists for difficult conversations, for handoffs, for everything. There are many different ways. You can use global rating scales. It's fine. I just have a lot of experience with checklists, and I find it very easy to give feedback to residents when you use a checklist. When you have a global scale, sometimes it's like, yeah, you didn't really get it. I didn't think you were ready. But when you have a checklist, you say, you missed this, this, and this. Let's go practice with it. So we've had really good luck with using checklists. All right, so what are the outcomes of this 4-hour curriculum? So in blue, we have the residents' pre-test skills. Remember, medicine and emergency medicine, these emergency medicine residents had a lot of central line experience. Here's the minimum standard. You can see that at the pre-test level, the residents were very poor. Now, at Northwestern, these residents were, before this program, just going to the ICU and putting in central lines. I have no reason to suspect that Northwestern internal medicine and emergency medicine residents are any different than emergency medicine and internal medicine residents at any program across the United States. So people were just not very good at putting in central lines. I have a little late-breaking information. I told you we're sending this out to our VAs, hospitals, and last week we were at one of the VAs in California. I wish I had been there. It's nice weather. And the person sent by the VA to do the train-the-trainer approach took the dilator out. I know there's some non-clinicians here, but thought the dilator was the catheter. This person had put in over 100 lines, was not familiar with the equipment. So, you know, when you start to look at things, you just realize that when you learn from see one, do one, teach one, and people teach you stuff, sometimes it's wrong. So when we actually get them into the sim lab or the classroom, we teach them the right way, it's very, very powerful. So here is the post-test effects. The resonance scores were very high, uniformly above the line. Look at these small standard deviations. Everybody went out into the ICU after this. Highly significant results. Everybody passes mastery learning, T1. What happened to patients when they got central lines? So here are complications. So these are T2, T3, patient outcomes, what they did in actual clinical care. So we had a research assistant in the ICU for a year watching and taking down data on central line insertions. And what we found was that the rate of arterial puncture, which had really been unacceptably high, the national rate is about 3%, went to 1%. The need for adjustments after the catheter was inserted fell, and then this was really very concerning. I mean, the insertion failure rate before our program was almost 20%. So 20% of patients had the risk of a central line, bleeding, pneumothorax, infection, but never got the central line because the insertion was not successful. So after the training program, the rate of insertion failure was 4%. So clearly you could see that the residents had taken the knowledge that they learned in the sim lab and then translated it into improved patient care at the bedside. There's no other plausible explanation why residents would become better at inserting central lines other than they had some training. So here's some T3 outcomes, which is CLABSI rates. And what we did was we worked with the infection control team to see if our training program had any impact on CLABSI rates. And as you know, Medicare considers a central line associated bloodstream infection a never event and doesn't pay for it. So this is sort of a hot topic at the hospital. And if anyone's interested later about selection of programs, I would impress upon you that the way that I've selected programs and been successful is because I ask the nurses and the hospital what the target areas are. And I try to combine that with the motivation of the learners, and that's how I pick things to study. It's worked out pretty well. So what this shows maybe I'll just use this. I don't want to pull the microphone out of the wall. But here in the blue is the MICU. And for years we had about, around this 5 or 3 or something infection rate per 1,000 catheter days. After the simulation-based residents were trained, the infection rate fell by 85%. So just to make sure that there wasn't some other factor we weren't thinking about, infection control tracks all the ICUs. So we mapped out the surgical ICU, which is just one floor below, but the only difference is that they don't have trained residents. They have the same nurses, nurses go back and forth. If there's any new nursing protocol, chlorhexidine baths, that would be on the different floors. So when we looked at the SICU, we found that their rate, although this looks bad, they were unchanged, this Poisson regression shows these two rates in pink were really unchanged statistically. So there was no change in a comparison ICU in the same institution at the same time, but our rates went down 85%. So that led us to conclude that it was the simulation training, had improved the insertion skills of the residents, and provided lots of benefits to patients. The mortality rate of a CLABSI in a MICU is about 50%. So this probably also saved some lives. Medical education, guess what? Okay. This was the paper that got me some traction at the hospital because I kept asking for more supplies. The gowns and the thing. I'll take any expired supply kit in our hospital, I'll take. But I did need the gowns and gloves and masks, and we bought an ultrasound. And so we worked with the quality team at our hospital. This is infection control, and this is one of the head quality people at the hospital. And we did a cost savings using actual hospital costs. And so what we found using the proprietary hospital cost data was, and this is not charges, this is costs, that when we invested in our simulation training program, the hospital had net savings of $700,000 just in 1 year in one ICU. And this program started in 2006. So if it was $700,000 then, and it was just one ICU, and now we've spread it through the whole hospital, we've probably saved quite a bit of real actual money. So this is when people start to pay attention. How do you get this line of evidence? This line of evidence took a long time. It took me years. It took me 10 years to get this. So I'm not saying you can do this all at once, but if you do that, if you think about education in a different way, you can actually talk to hospital administrators and quality people about things that really matter to them. This is just for educational interest and discussion. This is the T4 I talked about, the collateral effects. And this is the area that I really want to think about doing qualitative research in, working with Anders Ericsson potentially. But what happens to learners when they undergo a mastery learning intervention? I don't think we know the answer to this, but something happens. When you have a rigorous education intervention, something happens to the ICU patient safety culture that I don't think we totally understand. The only thing I can tell you is what we found with the residents, which I just think for all of us educators is kind of cool. So what happened is that we watched remember I told you we did this for second and third year residents. So this first part of a mastery learning program is a baseline test. So every year the second year residents would come a month before their ICU experience and come to the sim lab, and we would say, do it. Do a subclavian, do an IJ so we can see what you know. And so look what happened. This is the mean scores, and then the numbers are the percent of people who passed the test before they took the course. So we still made everybody take the course because we do other things other than just the technical things. We talk about line maintenance and removing lines. But over time, the pass rate went to almost 40%. So what these we called these unexpected collateral effects of simulation-based education, T4. Any thoughts on how this happened?
Interns were getting educated by the seniors.
That's right. So the senior residents, this is exactly right, in 2007 had learned from their senior residents as interns, and they came in and they were doing a terrible job. These residents learned from their interns who had taken the course, and by the time they were second years, they had already passed the test, and they knew how to do it. So something happened in the ICU that was different, because there was always teaching going on, right? These people learned whatever they knew, which was not much, from the supervising residents. We didn't train them to teach. We trained them to individually do central lines. But somehow they trained their peers so that they would also be competent. We don't understand this. So something to think about. It's sort of an area of future research, because if you can train one group and also get benefits in half of the next cohort, that would be great. What if we train third-year medical students to do something, and then as fourth years, they have already taught it to the third years? I don't know. Could be pretty cool. We have to think about this some more. So this is sort of an area of research for us, is what happens in the ICU, or what happens to the patient safety culture on the floors when you introduce simulation-based education. I don't think we totally know. Okay, now I want to just mention this because I think people always say, well, can it work here? Does this only work at Northwestern? Maybe you just have this one good teacher. I mean, how do we know it can work elsewhere? So in 2010, when Medicare came out with this never event thing, the Chicago Tribune did an expose on deadly infections in Chicago hospitals. And they listed all the Illinois hospitals and where they fell, because it was all public information. So they gave people a ratio, and if you had a low ratio, that was good because you had less than expected infections. If you had a high ratio, then that was bad because you had more than your expected number of infections. So NMH came out looking good, and we were happy. And Mercy, which is a hospital on the south side of Chicago with a predominantly underinsured and African-American population, had a very high ratio and was called out among being one of the worst in the state. So the faculty at Mercy knew us because we have been to meetings with them, and we know them. And they called and they said, could you train us to do this simulation thing? So this is at a hospital with no simulation training at all, with mostly, I think 98% residents from international medical schools, So it was not at Northwestern. It was at a completely different community hospital setting. And this paper's coming out in a couple months. I think it's online now, but their outcomes were exactly the same. So their residents, the pre-post, looked exactly like the slide I showed you. They were all around 50%, and then after training zoomed up to about 90% in the lab, T1. We had the chief residents trained. So the chief residents did the training, not anyone fancy. There's no simulator there, lab there. They used a classroom. And they had the exact same results in their CLABSIs. So they had a high rate here profiled in the paper, and then after this, the infection rates fell by 74%. There's an interesting chart in the paper that I don't have in the slides. That actually, after the second set of chief residents, they forgot about it. And we didn't know what was happening, and so we just forgot that they should have sent a third chief resident in July to be trained, or June, and the chief resident never came. And so in December 2012, we called over there and said, you know, whatever happened to your chief resident? And the program director was like, oh gosh, we forgot about it. We stopped doing it. So guess what happened to the CLABSI rates? Right back up. Then we trained the chief resident, and he started training the residents, and then they went back down. So I need to update that figure because it's really cool, the zigzag. But anyway, they're back on track now using the exact same protocol that we did. A couple other examples I'll just run through briefly. This is paracentesis. This is a simulator that we made using gelatin and some Penrose drains. It cost $52 to build this. We had a second-year internal medicine resident who made gelatin antecubital vein model. It's edible, apparently. Disgusting. And was teaching all of her friends. She has a thing about PICC lines. She hates PICC lines. I love this resident. And she wants to train everybody to do antecubitals with ultrasound, so she built her own model and baked it in her oven. That was pretty cool. So you know these things don't have to cost a lot of money. So this is the ultrasound compatible thing that we made. The commercially available simulators cost about $5,000, and we thought that was outrageous. So I think this looks pretty good. It's not bad. I mean, that's where you want to go. You know, you want to go there. Don't go there. So what happens when we train the residents on the $52 paracentesis simulator? Well, we also have some clinical outcomes of that too. So I don't know how your service is run here, but at Northwestern you have a choice when you have a paracentesis to be done. So a liver patient has fluid in their belly. The fluid needs to be removed either for their comfort or to rule out infection or malignancy. So either the clinical staff can just do it at the bedside, or they can send the patient to interventional radiology. At Northwestern, we have found no rhyme or reason for these decisions. So if anything, the patients who have the procedures done at the bedside are sicker. They have worse coagulation factors, worse Charlson scores, all those the things that you look at about how sick patients are. They're all worse on the patients and all the ICU patients are done at the bedside. So there's no evidence to me that sicker patients are going down to radiology. It seems to be just a decision based on if you have time that day or if you feel good about doing procedures. It's really not, or what your attending said. It seems very discretionary to me. So anyway, we looked at the clinical outcomes of patients who had a paracentesis, and we compared the ones done at the bedside and done in the IR suite. And we only looked at patients on our hepatology service, so we could have a very narrow group of attending physicians to take out that attending variability. We actually found that across the board, the outcomes of the patients having the procedures done on the floor by their unsupervised but trained internal medicine residents were better than outcomes of patients who went down to radiology. We found an increased length of stay of about a day, which is not surprising because they have to wait for the procedure. We found a much lower rate of transfusions, the odds ratios were over 4, that patients with the same coagulation parameters would get a blood transfusion. This is probably due to different guidelines. The AASLD says go ahead and do it, the Liver Society. IR Society guidelines have cutoffs. So they give a lot more transfusions to patients which have side effects and also add up to costs. So, and I cannot explain to you why there was a higher rate of ICU transfers in patients who had IR procedures. I don't know, it's just what happened. So our conclusion of this paper, and we have another one coming out about the costs. So the cost of having an IR procedure is about 5 times at our hospital, the cost of doing it at the bedside. Cost. And we see no evidence why they're better. So trained residents who do paracentesis provide at least as safe a procedure as highly trained experts who cost more. Similar results in advanced cardiac life support. We've looked at this over so many years that I have so many different columns I can compare to you. Here are untrained residents just going around and doing codes before our training program started, not very compliant with AHA guidelines. After simulation training, the residents did better, but then here are the mastery trained residents. So even this is just another example of how we did simulation training, and I wrote a paper about this, and I thought this was great. But 68% is not great. I mean, that's not great. It's better, but it's not great. So this, we're almost at 90%. Given, if you have a little discretion on clinical judgment, that's getting there. So mastery learning, again and again, is showing better benefits than either nothing or traditional education. And I want to just mention there are a lot of different studies that show this. So it's not just work we've done at Northwestern. I think there's certainly areas that have not been tapped yet and are ripe for research. But there's a lot of information on general surgery, some with emergency airway management, bronchoscopy skills. The work of Draycott in the UK is really amazing, what he's done with hospital systems and looking at newborns and using training of obstetric gynecologists and midwives and nurses to reduce shoulder dystocia, newborn brain injuries. It's really kind of inspiring work, all based around his faculty development and education sessions using simulation. I don't have too much time to get into this about communication skills, but basically when you teach people to talk to each other, you can reduce adverse events on the floors. And my point of showing this slide was to say that it doesn't have to be simulation. It can be communication skills training. This was a really powerful study in JAMA a few years ago. First author was a nurse, and they put surgical and anesthesia programs at the VA through team training. So all they did was they took people out of the OR and taught them how to talk to each other. And when they participated in this pure education program, they had an 18% reduction in surgical mortality. I don't know why this study doesn't get more attention. I mean, that's right up there with antibiotics, I think. So the power that you as educators that we have to impact patient care is huge. I'm just not sure that we're maximizing our contributions. And we probably need to. If you read the literature, there are a lot of quality goals that we're not at. We're not reaching all of our nation's healthcare quality goals. We haven't reached them in terms of preventable patient events, in terms of preventable infections. Some of these Medicare policies have not dented the incidence of these preventable infections. Just saying you won't pay for it. Forcing function, number 1 on both those lists I showed you, right? What was the most rated thing by the VA and by the Joint Commission was forcing function. We're not going to do it. And it doesn't work. It hasn't worked for CLABSIs, it hasn't worked for CAUTIs. And the reason for this is because behavior change is a complex process. People don't necessarily change their behavior because you tell them to, because you put a forcing function. A checklist alone is not very powerful. It's a checklist plus the motivated learner, why I keep highlighting attitude and motivation, and the norms of the place you work and the belief that you really can do it. Those are the things that change behavior. And who can do that? It's educators who can teach faculty and students. This is a really powerful study, the Dixon Woods work. This looks at the Pronovost Central Line program in Michigan. Everybody knows this. And this is where I think people get the idea that checklists are the answer. If you read the Pronovost papers carefully, you will find that it wasn't just a checklist. It was a whole education program. They had phone calls. They had experts come. Dixon Woods went and did a qualitative review of why the Michigan study worked. And the reason it worked was because of those things in red. The faculty loved the education partnership with a prestigious medical school. They knew there was a thing, and their culture said, we want to fix this. They were motivated. They felt a sense of team, and it was something very important to them. I don't know if anyone knows about when they took the Pronovost checklist to the UK, what happened? Does anybody know? So the UK already had low rates of central line infections. Their hospitals are all owned by the government. And the government read about the Michigan projects and said, we're doing that here. So everyone is going to use this checklist. So guess what? Nothing happened. Their rates were already low, but they didn't go down any further. So Dixon Woods, who I don't know, but I'm going to have to meet, went over there and interviewed the people who work in those hospitals. And she found out that they felt this was a government telling them what to do, and they didn't like this checklist, and they didn't think they had a problem. That's a lot different than the hospitals in Michigan, who felt a real team effort towards changing their behavior. So this is where I think educators come in. I think a checklist is one thing, but when you come at it from a framework of we're going to teach you to be even better at the job that you do, and we're going to help you take better care of your patients, that is when it works. I think that's sort of the secret of what happened in Michigan. Okay, last slide. So now we're back to the residents in the sim lab, and we talked a little bit about this, and I showed you a lot of thoughts. So we understand that they need to know the ACLS protocols, they need to know the AED, they need to know how to use the equipment. What are some other things that we've talked about that these residents need to know in order to run a really adherent, top-notch, actual ACLS event? Communication. Okay, I'm going to get there. Communication, anything else before I show the answers? Team training is right up there. Oh, there you go. So first of all, we should train to mastery, right? Because mastery is better than just putting them in the sim lab. We've shown that again and again. We need to do some communications and team training because it's very powerful. Maybe we should be up on the floors doing this. Where are the nurses? So I think a real weakness of our program is that it's too doctor-centric. Maybe if we want to get to 100, we need to have everybody who responds to the codes come. Where are the pharmacists? And then, I made a list of other things that I think, all these issues that we have not yet addressed. Sorry. So I forgot how many clicks I had. So these are all these other areas that we haven't really totally figured out yet, and areas where I think medical educators could play a really important role. I mean, who is better at thinking about communicating with patients than us? I mean, we teach that. So what do patients want? What do they expect? How can we involve patients on discussions about cost? People are so upset about their health insurance and worried. How can we help people make decisions that are right for them and consistent with their values and beliefs, but are also not wasting precious resources? I think this is a place where medical educators have a real role, in addition to some of the more procedural areas. So just to mention a couple people back home, the internal medicine residents, and then our research team, my mentor, Bill McGahey. So I guess I should put my new boss on this slide. I haven't done that yet, but Eric Nielsen, thank you. Okay.